We can talk about colon polyps. Where are the second years? Raise your hand. High, real high, so I can see you. All right, if I ask you a question, I want y'all to answer the questions. We're not going to ask the interns too, and I'm not going to look around, so just answer real fast, but I'm not going to ask many questions because we have about 20, 25 minutes to talk about colon polyps, which is about twice what I need for everything that I know that's important, but not near long enough to cover all the stuff that's in the paper here. But anyway, so one of the second years, why are we talking about polyps at all? First off, tell me what a polyp is. All right, don't sing out too fast. Go.
It's a growth in the
Speak loudly.
GI tract. A growth in the GI tract that could
Yeah.
be hyperplastic, could be
A growth.
neoplastic.
Yeah, we'll get into the kinds. They're growths, they can be about this big, not very big at all. So it's kind of like, why do we even talk about it? Polyps generally don't cause any symptoms. They don't block people off. They don't cause pain. They don't really bleed or anything like that. So why are we bothering to talk about polyps another second year?
Lead to cancer.
Lead into cancer. That's the only reason that we're interested in them. Polyps are pre-malignant. There's a thing called the polyp cancer sequence. Anybody ever heard of that? I hope they have. That's kind of the whole basis of all this. And in general, it's believed to take 10 to 17 years to go from a benign polyp to a cancer. So it's kind of a long lag time. That's in general. That's a bunch of PhDs sitting around and looking at data. I have my reasons to doubt that a little bit, and there are some other things that come up. But the main thing is, since 1992, that would be after I did my residency and fellowship, that both the incidence and the mortality of colon rectal cancer has declined. And that's felt to be due to more aggressive screening. The most recent thing that I've seen says that 50 to 60% of at-risk patients in the country have had some type of colon rectal screening. So, that's getting somewhere. We're not at 100%. In the United States, I saw two different numbers, 3 and 4, for the incidence of cancer being colon and rectal. But clearly, in industrialized countries, and particularly the U.S., it's the second leading cause of death from cancer. So it's pretty pertinent. The lifetime risk is 5%, so that's 1 in 20. What do we have in here? 40, 50 people, so 2 or 3 of us in here can get colon cancer, left alone. So look around and start to figure that out. But the whole other thing is, it's curable. And one of the things I look at, we go through a lot of stuff with mammograms and other types of screening and whatnot, but colon cancer and cervical cancer are really the only 2 types of cancer that we can intervene and try to prevent or have an early approach to and cure. So it takes a different approach. It's not as pessimistic as some of the things. All right, types of tumors. I'm not going to go through and ask this too much. By the way, I'm not going to ask a bunch of questions, so y'all can not worry about it. But pre-malignant polyps, adenomas are far and away the ones that count. And adenomas come in 3 varieties. They're tubular adenomas, tubulvillous adenomas, and villous adenomas, just like it says on the slide. The characteristics is based on how much of the different components they are. If it's like 75% tubular and 25% villous, then it's a tubular adenoma. 50-50 tubular villous. Even I can figure out how they're going at looking at them. All adenomatous polyps have some component of dysplasia, which means that you're developing atypical appearing cells that are leading toward cancer. And the dysplasia can count up to carcinoma in situ, or non-invasive cancer. when it comes down to the cancers, we have a spectrum. The tubular adenomas are the most common. That's the 75% prevalence. So of all adenomatous polyps, 3/4 of them will be tubular adenomas. But only 5% of those will be the origin of a cancer. So they're not highly premalignant, but they're premalignant. You move down the line and you have the tubulovillous adenoma, less frequent at 15%, but 22% of those will harbor a cancer. And then villous adenomas, pure villous adenomas are the least common, and that's 10%, but about 40% of those will go on to develop a cancer. I think Dylan was asking me questions about surgical recall, and I think those were the numbers that they were looking at and talking about for the students, so that gets in there somewhere. Size, 10 millimeters seems to be an important size for colon polyps. Under 5 millimeters, there's a very, very rare instance of cancer involved, but basically 10 millimeters or more is about a 3% incidence of cancer. All right, I do have a question. Were there any questions on polyps on the in-service?
Yeah, there was one.
What?
It wasn't directly related to this, but so somebody had a colonoscopy, they got a polypectomy, like mild abdominal cramping, they're going to get an X-ray and show some free air. What's your next step? Not tachycardic, not benign abdominal exam, but just some cramping.
All right, so now it's the second year is asked a question, so what was the correct answer? Did y'all hear it? It was a question of perforation after colonoscopy.
Serial abdominal exams and then 24 hours.
Yeah, if they gave the choice of serial abdominal exams, if it's not a large amount of free air, did they say?
Didn't say.
They pretty much painted the picture of a state.
Okay. Yeah, it's not uncommon. If we got CAT scans on everybody after colonoscopy, we'd probably be alarmed. Just like if the GI guys ever came in the operating room and watched the passage of a colonoscope and saw how much we stretch the bowel and how thin it gets, they'd probably quit. Because it is pretty scary. But if you've taken a polyp out and the patient comes in tender, there are a variety of reasons for them to be tender. Sometimes it's just as simple as gas. They just still have not gotten rid of the gas. Two, it's they can get a chemical, we call it a chemical reaction, but they can get a serositis on the cirrhosis of the bowel from the burn, and they can be tender from that, or sometimes you perforate them. And small perforation with some free air, localized tenderness, stable patient, antibiotics and serial exams is the appropriate thing to do. If they're generalized tenderness, showing any signs of particular tachycardia, looking like they're sick, then they're going to need to be operated on and have the injury managed. Yes, sir.
Can you manage those injuries? Say if you do operate, you find a small perforation, can you manage those as primary closure, or can you do a section?
You could, but I have always resected them because you had a polyp there, and there may be, something abnormal with your pathology. I mean, if they come in the night of surgery, you don't have your path report. I've had them come in a day or two later, and I ran down the path report to find out. But if they're a day or two later, then they have too much reaction going on to do something local. So generally, I've resected them just to head off getting a bad pathology finding.
So like a formal right hemicolectomy or?
Yeah, that's when you start wanting to be really cheap, and then you're going to come back and you get 8 lymph nodes, they have a cancer, and you say, ooh, I wish I had taken one more vessel as I took it out. But yeah, you can generally take it out. Not very common. All right, second years. What's the incidence of injury during colonoscopy? 1 in 10, 1 in a million?
1 in 1,000.
1 in 1,000 is a number that's been used a lot older. It's probably trending more toward 1 in 10,000 now. It's trending a little bit higher. If you do and it's something that depends on what type of therapeutic procedure you've done. Snare polypectomies and things like that have a little bit higher incidence of complications. But
What's
back
the
to
acceptable rate for getting an ACV after a colonoscopy?
did y'all hear that? The question was, how often do you need to get a barium minimum after a colonoscopy? Okay, second years, what's the answer? 1%, 5%, 15%, 50%.
5%.
About 5%. You should have a completion rate of approximately 95%. When you first start out, probably closer to 90%, and then it's gonna go up. What are you laughing about?
It's just, sometimes they're hard.
Sometimes they're hard.
I didn't complete one yesterday.
Oh my goodness. When Boudreaux and Scarcliffe were here as our fellows, I had to help them both on their last day finish their colonoscopies. So, and they were both very good. All right, but the general point here is that as you range from tubular to villus, the cancer rate goes up, the frequency goes down, and as size gets bigger, then you're more likely to have cancer. All right. Other polyps that we see listed, and I can read: hyperplastic, inflammatory, juvenile, and hamartomatous. Those are generally considered not premalignant. There are exceptions for 3 of them, I think. I think if you get enough hamartomas don't have any, they just bleed. Second-year Wesson syndrome associated with hamartomatous polyps. It's an easy one. Say it louder. Peach-Jaggers. You see those. They turn out to have numerous polyps. I think Peach-Jaggers is the oral pigmentation that you can see, and bleeding is the primary concern with Peach-Jaggers, and they can obstruct. There is a juvenile polyposis that can have an association with malignancy. Rare. So wouldn't bank that away as the first answer for just about anything. The thing about juvenile polyps, it'd be an open-ended question. Anybody know anything about juvenile polyps? But as the name suggests, you see it in younger people, but it's really also a pathologic finding of immature types of polyps. But juvenile polyps can grow to be quite large, and they bleed, and that's something to note. But they can also auto-amputate, and so children can have histories of bleeding, and then it quits, and often they've had juvenile polyps that bled and then auto-amputated. And so that's kind of a little bit interesting and cool. Hyperplastic polyps are interesting in that there is a hyperplastic polyposis that does have some premalignant characteristics to it. Hyperplastic polyps in the rectum are not considered to reflect the increased incidence of cancer in a patient or cancer potential, but hyperplastic polyps in the right colon are more worrisome, as possibly pointing at a premalignant concern. So second year is not related to this slide at all. Where do most polyps and colon cancers occur? So you got 2 choices, right or left? Left, that's right. Is that hard and fast in stone? I see some head shaking.
That's where most of them are, but you can still get them on the other side.
My guess, what I'm thinking is that recently there's been noted to be a trend more proximal for colon cancers and polyps. The incidence of right-sided lesions is increasing. And whether that's related to screening and clearing the left colon or changes in environmental factors, things like that, don't know for sure. This one's a kind of a hot in vogue topic these days, sessile serrated adenomas. 5 years ago, or maybe a little longer, I wouldn't have had a clue what you were talking about, and so it's fairly new. They didn't happen to ask that on the in-service, did they? Nothing on there. They used to be called hyperplastic polyps. They occur more often in the right side of the colon, and they're pertinent, so they have hyperplastic characteristics. They tend to be kind of big, a couple of centimeters, flat, fleshy-looking polyps, real easy to overlook, especially if there's any stool in the colon. And they have a very significant premalignant potential. They're associated with microsatellite instability, which goes along with Lynch syndrome and hereditary non-polyposis colon cancer. I have trouble saying all that, but we'll put it up in a minute. But they have a fast progression to cancer. Some people say that approximately 2 years to progress to cancer. So that's like way outside the bounds of tubular adenomas and things like that. And you need to pay particular attention to it. When you get your path reports back, you need to look at it and think about it clearly. These people need to have their polyps completely removed and followed very closely because they have a very significant malignant potential. So those are kind of important. On talking about malignant polyps, the depth of invasion, if there is an invasive cancer, called Haggett levels, and really this has changed a little bit. I've always said that if the neck was not involved, then you're okay, and you've done enough by doing the polypectomy. On sessile polyps, it's all determinant if it invades the muscularis mucosa, the muscular layer, muscularis propria, yeah. If it does, then that patient needs operating. If it's down in the neck and you have a couple millimeter margin, you're pretty good. Miles, did we ever get an answer on that patient? The guy with the malignant polyp? Did you ever talk to the pathologist?
Yes.
And what'd they say?
They said they didn't think it was, pedunculated, they thought it was sessile.
They thought it was sessile, of course it was dictated as pedunculated.
Yes, sir.
How deeply was it invasive? How deeply was it invasive?
Submucosa.
Submucosa. So what are we gonna do with that patient?
Yeah, she's a patient. Like right up there. Good colon.
I need to.
Yeah, Ariel needs the name, and I'm still not real convinced. You have, Patrick?
I thought you said if it has to go to the muscularis.
Generally has to go down to the muscularis. So, the muscularis propria, the muscle layer of the bowel wall, to involve it. But the whole point is not every single one needs to be resected. All right, on the hereditary non-polyposis colon cancer, there are 2 sets of Amsterdam criteria, and there's another group in there, but the central thing is the 3-2-1 characteristics, and that's the thing to keep in your head when you're talking to patients and looking at 3-2-1. That's 3 relatives with colorectal cancer, 2 separate generations. So it can't be like 3 brothers or sisters, or it's kind of hard to have 3 mamas and daddies in general. But so it's going to be 3 relatives, but 2 different generations. So it'd be like a parent and a brother. Do you have a question, Miles?
Yes, sir.
Okay. And then one of those relatives has to be less than 50 years of age. So there's going to be someone young. The differentiation between Lynch 1 and Lynch 2 is that the Lynch 1s are just colon cancers. The Lynch 2s have the extracolonic cancers, predominantly gynecologic, proximal GI, and urinary tract cancers. So the pertinence between these patients have a very high risk of cancer. They need to be followed more closely. In the questions here, they had a topic about whether these patients should have a subtotal colectomy or not, and they advocated along the lines of a subtotal colectomy. There's a little bit of dispute about that if the patient presents and they have multiple right colon polyps or right colon cancer. Some people would say to do an extended right colon resection. Other people would say to do an abdominal colectomy. These people are not at particularly greater risk of developing left-sided cancers. So a little bit of a question there as to how much of the colon to take out. But you need to be aware of these people. You need to get them into genetic testing. And on the lines of genetic testing, when you get out, there are kits that you can buy or labs that you can send lab work to order the genetic testing. I know they're there. I don't do it. There are good studies that show that doing office-based genetic testing, just because you have lab tests available, that in excess of 50% of patients will get wrong advice and get wrong tests done looking at it. These people need to be sent to a genetic counselor. That's what I do with them. There's a genetic counselor at Feistweiler, and then there's a genetic counselor at Schumpert. And they go through and they first off figure out if the patient needs it anyway. Their history may not be quite as hard and fast as I may have thought. And then when they get the results, they bring them back in and explain it to them and give them the correct answers from it. So that's just a word to the wise. All right, screening, and I can hit this kind of quickly. Anybody over age 50, if someone has a family history of colon cancer being first-degree relative of cancer or polyps starting at age 40 or 10 years younger than the index. So if mama was diagnosed at age 40 with colon cancer, then you start the screening at age 30. Not real hard.
So if somebody was diagnosed at 61, you would start at 40?
No, you start at 40, yes. Okay, you still start at 40, but it's just, does it ever get pressed down? And it does if you have young relatives. And then you do, not really screening, but diagnostic colonoscopies for GI bleeding, heme positive stool, iron deficiency anemia. As I pointed out to Ariel yesterday, those are the indications for screening. And does anybody see up there plans for a hernia repair? I'm sorry, it's not in one of the indications. Now, you may do them, you may not get paid for it. The patient may get real mad when the insurance doesn't cover it. But you need to press hard to find some bleeding.
Just take a really thorough.
Yeah, find some bleeding. Now, there's an old study that I didn't see in any of these things I read through, but I still find it interesting that when you find cancer in an asymptomatic patient from screening or looking, you have an 80% chance of curing them. If the patient presents with symptoms, you have a 20% chance of curing them. So that's a reason to be looking. Won't spend much time here on the different screening things. Colonoscopy is the gold standard. There are excellent studies showing the decreased incidence of colon cancer and improved survival, which is important. There's one large study that estimated that when polyps are removed, that you decrease the incidence of cancer in those patients by 90%. But up at the top you see that screening reduces colon cancer 70 to 90%. I point out to patients, neither one of those numbers is 100%. So we wish that it would get rid of all of them, but it does not. Some patients come back and fall within the cracks in the intervals. They may be some of those sessile serrated adenomas or other aggressive components. But you can make a big headway. But in general, those are the different recommendations: occult blood 1 year, DNA stool screening 1 year, the others at 5 years, and colonoscopies 10 years. That's in normal risk people. And then the cost is $10,000 to $25,000 per year of life saved. and that's less than the cost of doing screening mammography, which gets a lot of interest. I also heard someone talk about once that seat belts are required in cars, and it costs money, and we pay for them, but per life saved is probably 10 to 20 times more expensive to put seat belts in cars than to do colonoscopy. So it's but that was a big argument made before it started being paid for. All right, second ears. Somebody look at that one and tell me which ones of those says annual colonoscopy? None. So, good answer. So, I hear it too often or see notes in clinic, patients due for their annual colonoscopy. Talk to me before you set somebody up for an annual colonoscopy, because it's going to be rare that that's going to be indicated. In fact, now there are guidelines that are looking at it, and basically you have to have documentation why someone's getting an interval colonoscopy at less than 3 years. So be prepared. It's here. They're starting to monitor it and look at it, and I'm going to have to start paying closer attention. But if you scope them at less than 3-year intervals, there needs to be a specific reason, and that's going to be multiple polyps greater than 10. That's not greater than 2, and large polyps. But the one reason to come back in 1 year is if you're not sure you've taken it out. If you've not cleared the colon, then you can come back at a quick interval. Sometimes I do it at 3 months. All right.